Shafi. Thank you for the lovely welcome. Good to see so many of you here. Yeah, as Shafi said, my name's James O'Shaughnessy. Once upon a time, I was a politician. I'm now in consultancy. I run a business called New Market Strategy. We're a market access consultancy in health and life sciences. So we work with companies that are trying to launch and scale their products and services in the UK. It gives me enormous pleasure to host this session, in fact, to sponsor Giant Health for the first time. And in doing so, we're going to be exploring the topic of digital mental health, how to provide support at scale. With me, I have two fantastic speakers, only one of whom is on the screen, but the other is our great surprise guest. Who is Sir Norman Lamb, who is chair of South London and Maudsley Hospital, which is, I'm sure many of you know, is one of the UK's leading mental health hospitals and trusts. He's a former Minister of State for Care in the Department for Health and Social Care, a former chair of the Science and Tech Select Committee, and was Lib Dem health spokesman for many, many years. And he's lots of other things besides, as Norman will tell us about. And also joining me is Dr. Saira Ghafoor. Saira is the co-founder of CIMA, which is an online psychotherapy provider, as well as a clinical evidence company called Prover. She's the lead for digital health at the Institute of Global Health Innovation at Imperial College, and as managing to fit around all of that, she's also a respiratory consultant. So we really do have two fantastic panelists. I'd like to invite you both up to join me. We're going to hear from Norman first, then from Saira, then I'm going to ask a few questions, and then we'll move into audience participation mode for whatever time allows. So, Norman, I'm going to invite you to go first. I'm going to come and sit down, and then Saira, after you.
Thanks very much, James. Good to be here. I was going to mention, I think we've got about 5 minutes each, haven't we?
Exactly.
So I was going to mention a couple of, or three particular initiatives that I think are quite interesting. The first is that relates to the Mental Health Act. My view is that we incarcerate far too many people in this country, that we breach their human rights, and we do this at enormous cost to the state. About 50% of our mental health budgets are spent on locking people up, which is not particularly ambitious for people. And a big part of that is the way in which the Mental Health Act works. There's a particular section of it, Section 136, which allows police officers to basically pick people up in a state of crisis in a public place and take them to a place of safety. Now, this is either an A&E department or a specific health-based place of safety at a mental health trust. In London, vast numbers of people turn up at A&E and they get stuck there. A&E departments are like a war zone at the moment, but there are loads, the majority of people who need admitting to a mental health bed end up waiting for more than 12 hours in an A&E department, and often can wait for days there, literally days, and often with a police officer present with them. So this is a very dysfunctional system, and we know very little about the numbers involved. So there's been a big project to digitise the Mental Health Act, starting with Section 136. So at long last, over the last few months, we started to get really rich data across London. This is a collaboration between NHS and police, so that when a police officer picks someone up, instead of having absolutely no idea who this person is, they may well be someone who's been detained multiple times before, going through this awful revolving door. But the police officer on the spot, historically, has known nothing about them, and so really has no alternative but to take them to A&E. The potential prize is that if the police officer can either speak to a clinician who can access all the details, or the police officer can access the details themselves, then we may well be able to get that person to a safe place, a less restrictive place, much less anxiety inducing than an A&E department, relieving pressure both on the police, on A&E departments, and on mental health services. And alongside that, there's some brilliant research being done at my trust, which is looking at if we use advanced statements agreed with the individual to give their priorities for what should happen to them in a moment of crisis. And if we can make that accessible digitally, combining these two things could be really game-changing. We know that advanced statements where people give their own views about what should happen to them in a crisis can significantly reduce the number of people who get detained under the Mental Health Act. So there is a big opportunity here to enhance human rights and to make the system function more effectively. The next thing I wanted to mention is a digital dashboard that we've been creating at the Maudsley, where we've got about 370,000 people that have had contact with our services who are alive, living in our communities. And up until now, we've never interrogated this extraordinary data that we hold on such a large number of people. So we started with psychosis, which is the most significant issue in inner city London. And we're able to plot where everyone who has psychosis, who's used our services, is from. You can literally drill down into individual estates, individual GP practices. You can see where the hotspots are, the potential for preventive work to engage in community work to stop the psychosis occurring in the first place is enormous. And so I think there's a potential big gain here, along with the ability to manage people's health once they're using our services. So you can go from the population level right down to the individual, and you can monitor who's been using pharmaceuticals appropriately, where there may be gaps, and so on. So the ability to interrogate this data, I think, has enormous potential. And then the final thing just to mention is a digital platform that individual patients, people can use, which enables them on their phone to connect with their clinician, to set up all sorts of individual goals that they might be wanting to achieve, to manage their own health more effectively, to take control in a way. It's a significant, it offers significant potential to transfer power to individuals rather than keeping it with clinicians. The challenge is that it's not been adopted by nearly enough clinicians across the trust. And so its potential simply isn't being met at the moment. But I think it has the potential to transform the way we support people in acute mental health services.
Thank you, Norman. I mean, so much there to get our teeth into, which we will in the Q&A.
Sure.
Just hand it over to... and I think very exciting what's happening at the Trust. I guess at SLAM, it tends to be quite at the acute end of things. You're dealing with people in crisis often. CIMA is at the more mild to moderate end, where, of course, the burden of disease is tremendous. So it'd be great to hear from you about what you're doing, the impact you're making.
So we set up CIMA in 2018. My co-founder is my sister, who's actually called CIMA, and it's named after her. So we set up in 2018, and very much it was the access to therapy. So you see endless waiting lists across the board in the NHS. So access to therapy and making sure people had good quality of care at the end of the day. So we naively set out on our journey to set up the company, neither of us having a business background. So we set up, I had an interest in technology, in startups, etc. My sister coming from the clinical side. So we set up the company in 2018, developed the app on the App Store, and suddenly we thought, oh, we're going to have a whole load of clients coming through. We were very naive. So initially we started with a B2C model, thinking patients would come to us, but quickly realised unless you have very, very deep pockets, you're not going to get very far in this game. So then went back to the drawing board, decided on a more B2B approach, working with the NHS, working with insurance companies, other corporate providers as well. And again, it was a very slow journey at the beginning, and then COVID happened and literally things changed overnight. So in that first COVID year, we saw a growth of about 5x, and that's continually grown since then. And I think it's that change of clients coming to us whether it's referrals from the NHS, insurance companies, etc. But people have changed the way that they use telehealth services. And as James said, we provide that kind of mild to moderate end of psychological therapies. But one of our key things was that we use clinical counselling psychologists that can provide more than CBT therapy. So you can do mild to moderate and the more enduring end as well. And one of the really important things for us was that quality of care side. So kind of putting on my Prova Health hat as well, and that evidence generation side of things is kind of making sure that we're measuring clinical outcomes, we're looking at patient feedback, we're looking at therapist feedback. Not everybody is suited to a telehealth role, and kind of using all of that to improve the service. Stop there.
Thanks, Sarah. So it's just worth putting what we've heard from our two speakers in context. And I'm sure everyone knows this, but you've just talked about it there, Sarah, which is the huge increase in mental illness, or depression specifically, during the pandemic. Its incident basically doubled, although it's gone down slightly since. But that's against the backdrop of increases over time anyway. And of course, the fact that only around between 1 in 4 and 1 in 3 people with a diagnosable mental health illness actually get medical attention, which I always think the sort of appalling analogy to think of is, imagine if you broke your leg and you had a 1 in 3 chance of getting hospital treatment for it. It's unimaginable. But that is the situation we are in mental health, despite huge investment, despite innovation of the kind that we've been hearing at South London, Maudsley, CIMA, and many others. So I guess the first question I wanted to pose of both of you is, why is it so hard to create change at scale? Scaling is in the title of the discussion. We have great research happening at South London Maudsley. I've seen brilliant use of VR, for example, in treating people up at Oxford. Companies like CIMA have got Big Health represented here. I think you were talking about Thalamus with the London Mental Health Act. There's terrific examples of innovation, but we have not yet seemed to grasp the opportunity of doing that at scale, something you alluded to first, Norman. So Sarah first, and then Norman. What can we do about that? Is it just a clinical problem? Is it a money problem? Is it all these things? Tell us.
I think all these things, but certainly I think we have such brilliant innovation going on in the NHS and across, and our life sciences industry is really well supported. Lots of brilliant inventions, innovations coming out. However, it's that getting to scale, which is always a difficult part. There's a couple of major things that we've really not addressed across the NHS, certainly. One is actually reimbursement. How are we paying for any of these technologies? How are patients able to access them? Is it out-of-pocket expenses? Is the NHS there to pay for them, or are they going to be prescribed in some way? And certainly if you look at other countries such as Germany, they've kind of tried to figure out ways to do this, but it's still very early stages. The other thing is clinical adoption. So one of the key things that you need to do for that is to make sure clinicians are on board and know what digital therapeutics or tools to prescribe. But very often we don't do that very well. And certainly losing things like the NHS Apps Library. Clinicians don't know what to prescribe for their patients. And then the last thing is looking at patient adoption as well. What are the kind of barriers there? How are we educating patients? How are we bringing them on board as well? And until I think we do all of those three things, it's very difficult. And I think one of the major things is clinical outcomes as well. We need to make sure any innovation is fit for purpose, and we've got all of the evidence behind it to make sure people are happy to use it.
Thank you. Norman.
Well, I agree with all of that. I think also we've got quite a dysfunctional, broken treatment model in the NHS in terms of mental health. It's very heavily very heavily limited in terms of access. So you have these extraordinary waiting lists. You could be waiting as a teenager for up to a year for access to treatment. But the people working in this system don't know any other system. And in the last discussion, someone mentioned that health is a conservative with a small c, James, hasten to add, a conservative industry. And there is a lot of inertia, and also we have to confront it. There's quite a lot of vested interest as well in maintaining the status quo. And I mean, I remember when I first arrived at the Maudsley, I said, you know, we were designing our new strategy, and I said, there must be a much greater emphasis on how we prevent ill health. And the response I had from a very senior person was, we're not commissioned to do that. And it's sort of like, yeah, but do you not want to try and take control of our destiny and try and be more effective in supporting the people that we're serving in this community? And of course, now we have ICSs where we are part of the organisation, the structure of the NHS in our locality. So we have no longer any excuse to say we're not commissioned to do this. We just have to get on and do it. And we do it in collaboration with third sector, with business, with local authorities, but also critically embracing technology.
Yeah. So just a great segue to this point about prevention, because of course, with the burden of mental illness rising, one answer is to try and have a service well, part of the answer is trying to have a service that can actually cope with that level of illness, which of course we haven't done historically. But another part of it is to try and prevent it occurring in the first place. Now, as I understand it, there is still a great deal of debate about what actually causes mental illness, what's causing the rising burden. There's health factors, there's social factors, economic, you know, we can get into all of that. But nevertheless, it's obvious, I guess, that sort of paradigmatically we need to get into the preventative realm. So what are the best interventions or innovations that you have seen or is happening in South London, Maudsley or elsewhere that are actually having that impact that potentially could reduce the increasing flow of mental illness further down the tracks?
Digital is very much part of this. I should also declare an interest. I chair the advisory board for a digital mental health company called Kooth. Now, Kooth is contracted to the NHS in most of the country, particularly on children and young people, service up to the age of 25. It basically enables anyone where the NHS has contracted for this to be available for young people to go onto their phones, to access the site. They can do so anonymously, which I think is an enormous potential benefit, because, I mean, I think of our own oldest son who diagnosed with OCD at the age of 16. For 2 years, he'd lived with this without telling anyone, because he was so ashamed of the dark thoughts that he had stuck in his head. If he had been able to explore and find out anonymously what was going on in his head through an app that gave all that information to him, I think it would have been an enormous relief for him and would have enabled him to get help far earlier. And you can do this at population scale. That's the really exciting thing. Anyone in the community where this is available can access it. So they can access a whole load of information about mental health and the things that they may be experiencing. They can go into moderated chat rooms so they can talk to others who are going through similar experiences, or they can get access one-to-one with a counsellor. And without waiting. So, you know, this sort of approach has to be part of the solution. But alongside that, you know, I said earlier, we spend about 50% of our money in the NHS on locking people up. Now, this is not ambitious for people. And here's the thing, it has a disproportionate impact on young black men. And that, in this day and age, is not acceptable. You're something like 6 times more likely to be detained if you're young and black compared to if you're young and white. So I'm on a mission to change the model of care in this country. Trieste in northern Italy is a good example of where they have a much more enlightened approach. They lock up far fewer people. The world doesn't cave in, but supporting people in the community, enabling them to remain at home, avoiding institutionalizing people, also has to be the answer to a more civilized approach in the 21st century to people who experience mental ill health.
I'm sure we would all agree. So, for Sima's work, you've actually do a lot of work not simply with patients, but also with staff members, both inside the NHS and outside. So, it'd be good to hear about that, the role that you think that has in a preventative agenda. So, not just dealing with illness, but stopping people from getting unwell in the first place.
Definitely. So I think, again, this was very much through the kind of start of the pandemic, and we saw lots of staff members, whether it was working with the NHS or working with other commercial companies, and the burden of stress, anxiety, doing certainly in the NHS, as an NHS doctor myself, only working part-time, seeing my full-time colleagues literally, that kind of pushing people to the brink, essentially, and making sure that people have access to rapid mental health support. So I think that was really important for us to work with the NHS during that time. And we're one of the main telehealth providers for the NHS staff service. But also working with other commercial companies as well. We've seen this massive move to hybrid working, or whether it's kind of complete remote working. Staff then want to see other benefits as well. So if you're not going into the office, if you're not meeting your colleagues, there's lots of other things that crop up then. Things like isolation, working on your own. So it may be great that you're able to work from home, but it brings up other problems. So staff expectations as well, to make sure that actually those are met, what else is being offered. And also looking at the workplace, if you see the number of kind of sick days that are attributed to stress and anxiety, and that is increasing year on year, or people are actually more able to talk about their mental health and it being an issue in the workplace. And there was a study done, I think, by Deloitte last year, the year before, and it was if an employer spends £1 per employee on mental health, they get £5 back in that presenteeism. So it's making sure that it is that early intervention, people, employers, workplaces recognise that mental health is an issue, and it's that early intervention. So whether it's apps for self-help, it's access to telepsychology services or other services, it's kind of making sure that is an appropriate agenda for any kind of employer.
Yeah, no, thank you. And I think you made a point about this kind of care often being inaccessible to people because of cost.
Yeah.
The NHS is under financial pressure, so I guess there is a role for employers, other people in society, to actually take on that responsibility, which is maybe points to a slightly changing model of care than the one that we've traditionally had. So I'm going to open it up to questions. We've got 10 minutes or so, I think, for questions. So hopefully that'll be plenty of time. There's a gentleman at the front here, and then a lady at the back.
Is there a roving mic?
Shout, I think.
So you both mentioned access to services through digital technology. You mentioned telehealth. We're a provider to the NHS of services.
Who are you and where are you from? Yeah.
So we specialise in ADHD mental health, company called ADHD 360. I'm a former police officer who found offenders with ADHD through the justice system as opposed to the health system.
Yeah.
So left the police, started this company. We now treat 1,000 new patients a month using digital and telehealth as a combined structure to beat the waiting list phenomenon that the NHS has. Yet still, despite having 5 contracts with the NHS, we can't convince the NHS that this is the way forward. How do we manage to do this at the strategic level when we're managing quite well at the tactical level?
That's a great question. And you've dug right into, I guess, the sort of big structural weakness in the way the health system runs. Great innovations, but struggling to scale.
Yeah, I mean, it sounds so familiar, that story. And of course, you can convince one trust or one ICS, but that's just, achieved a success in one geographical area. But what about all the rest? I mean, I think we have to try to get ministers, if they will stay put in their positions for more than a few weeks, we have to try to get them engaged in this subject and thinking more creatively about the solutions. The bottom line is that the way the system functions at the moment is not sustainable financially. Everything is stressed about the NHS mental health system. Everything is full up. Waiting lists are horrific. people are routinely failed across the country by our NHS. And so we've got to start getting ministers and also NHS England recognising that the only solution is innovation and a willingness to try new ways of doing things. You know, even then, because we've got quite a dispersed system, it's quite difficult to get the system to respond. But once you start to build up an evidence base that you're delivering a return on investment, as it were, then you might start to make some gains. But I'm not beginning to claim that it's an easy solution.
Completely agree there, and had exactly the same experiences as you working in policy land, working in the NHS. Actually, who's the right person to go to, who can actually make those decisions. But it's very much what Norman was saying. How do you make it easier for people to create change? And we're not very good at doing that. So it's very much looking at other systems. How do you bring innovation to scale? Looking at, again, I'll go back to the German system, although not entirely fit for purpose. But actually, if you make it easy for ICSs or trusts, etc., to bring in an innovation, if you can already say, here, this is an innovation that's been through a kind of evidence generation process, it's got outcomes demonstrated here, it is fit for purpose, you can use this. So instead of them having to do their own kind of due diligence and going through all the kind of checks and balances, it's already there as an NHS approved innovation that they can take up. So until we've got something like that, we're again putting those barriers in place, and again putting in that reimbursement model as well. Unless we've got that set out, it's very, very difficult, or we make things difficult.
Yeah, I think that's right. I mean, I think we'd love to be able to provide you with the shortcut to national success, but it is about having a robust evidence base. But I think ultimately it does come from some kind of dedicated reimbursement, and there are goodness knows how many technologies that are actually demonstrated to be cost-saving for the NHS that the NHS at scale doesn't use. So there's something fundamental there that needs to be addressed. And I'm sort of with the panel that I think it probably does come down to funding. There are transitional issues around clinical usage and patient acceptability and so on, but without funding, it's hard to see how those things will happen with scale. That funding, of course, is available for medicines. So that might be another, one route is to actually go down a genuine medical reimbursement route rather than a digital one.
It is deeply frustrating that we're spending a fortune on antidepressants, which we know where the evidence base is not great for the way in which they're being used, and yet we're not willing to invest in things that do have a strong evidence base.
Indeed. Lady at the back.
Kind of you. Thank you. So I was extremely heartened by your comments, Sir Norman, about the fact that we lock up people. I was for years a member of a mental health panel, and I've seen myself the violence that people live when they are arrested for a tiny misdemeanor in the parkland or something like this. I'm also by background a human rights lawyer, and so it really frightens me when I see that the UK is actually discussing getting out of the European Convention of Human Rights. But coming back to mental health, with all the horrors I've seen happening, which actually was, the film Flights Over a Cuckoo's Nest, is stuff like this does happen. Is there any link? So I was really interested by the link you mentioned between the hospital, the mental health hospital, and the police, which is something I advocated about 15 years ago in West London. Is there any link also with housing? I actually work at the moment in homelessness, and I know one of the big issues we had with what we call our revolving door patients was housing. So they come to the hospital, somehow they're released, they get out in the streets because there's no sheltered housing, they come back to hospital. And if there was a link with housing, I think that would actually do one of the links, not everything, but one of the links that is needed in that area.
Well, I totally agree with you. In my sort of the vision that I have for the future of mental health, housing and employment play a big role. You know, if you think about what keeps us all sane and functioning, it's the foundation stone of having a house, a safe home to live in, and having a job that gives us dignity and self-worth. And yet, for so many people, they don't have either of those things, and we expect them to get better in an institution where there is a lot of violence. And, you know, I go on to mental health wards and I ask myself the question, would I want to come on to here myself, or for our son to be placed on one of these wards? And the answer clearly is no. So if it's not good enough for me, I don't think it's good enough for anyone. And there is a more civilized alternative. Of course, some people will need hospital care. I'm never going to sort of seek to deny that. But there is so much better use we can make of the resources that we have available to us by ensuring that people get into good homes. It costs about £600 a night to keep someone in inpatient care. It costs about £180, £200 to be in a decent home. And, you know, what is a better alternative for most people? So I think we've got an enormous opportunity to liberate quite a lot of money to shift into a more ambitious and more civilized approach to mental health.
Sarah?
Yeah, I think very much following on from that point, making sure it's looking at the intersectionality of healthcare and especially mental health care, making sure housing, education, socioeconomic status, and making sure that we are serving those underserved communities that do need additional help.
Time for one last question, if there is one. Lady here at the front, would you like the mic?
Thank you. I guess just building on the previous question and then coming back to the theme around prevention, I guess my observation, so I work with a number of different digital mental health ventures, and I'm an investor as well. And one of my observations is we're not short of innovations. I mean, we've got so many great innovations. But back to the point around scale is I observe that many of these companies end up pivoting and changing their proposition to gravitate towards where the pot of money is in the NHS. And the pot of money in the NHS tends to be aimed at plugging service gaps and addressing backlogs and other issues. And so what we never get round to is actually putting these innovations into the services and the places that they were actually designed for, because these amazing entrepreneurs and innovators saw a gap and saw that there was something powerful that could be done to actually stop people getting into the system in the first place. But the money just isn't there for them to be able to get that early traction. And so they end up just kind of pivoting the product to go where the pot of money is. And just to give a couple of examples, you know, services, I'm just going to pick on a couple of women's health examples, but we know that women, prenatal and post, are prone to depression. We know that they shouldn't be on antidepressants. And we also know that if they do fall to being diagnosed with depression, it has an impact on baby and the entire family, which is a much greater burden to the system. But what we don't do when they're in the maternity pathway is start looking after their mental health. We don't give them access to these innovations. And why? Because there isn't a pot of money there to do that. So, you know, I'm just interested in what the panel think about that, because I think until, you know, the NHS isn't set up for prevention. We know that. We acknowledge that. It does a great job at repairing. But until we can start creating pots of money where we know people are at risk, you know, and we start dropping some innovations in there, we're always just, you know, going to be spinning wheels.
I completely agree with that. I think there's so many skewed incentives across any healthcare system in terms of innovation and what you can do, and especially if you are taking on investment and your investor wants return on investment, what are your metrics, etc. But I think some really heartening story, I mean, one of the best stories in the NHS is the use of continuous glucose monitors in type 1 diabetes. So that's very much the National Diabetes Strategy that has been working alongside the Accelerated Access Review And very much that money has been channeled into, we know that this is a huge problem. 1 in 4 people with diabetes end up in hospital at some point, or 1 in 4 people who are in hospital have diabetes. So it's one of those things that is massively underpinned by strategy, national strategy, money along with the strategy. And that has made massive differences. So I think for really tricky, difficult to solve problems, that's the kind of thing that's needed, is a strategy alongside the money. Otherwise, like you say, there are skewed incentives and innovators will go where they're going to get reimbursement for that product at the end of the day.
Well, the system responds to incentives. Too often they're skewed, as we've heard, and I totally agree with that. But I think it does raise the question, could we design incentives better to incentivize preventive health? When I was chair of the Science and Technology Select Committee, we did a report on evidence-based approaches to respond to adverse childhood experience in early years. We know that there's a very strong correlation between bad things happening to you as a baby and a toddler and the emergence of mental ill health, poor physical health, poor educational attainment, worklessness, everything else. And yet we don't apply the evidence-based interventions routinely across the country, despite still spending quite a lot of money on early years, less than we used to, but still we're not spending it in accordance with the evidence. So let's create systems and incentives that encourage commissioners in localities to follow the evidence and to focus much more on how we prevent ill health and also prevent a deterioration of health, because even when there are early signs, so much better to intervene earlier through this sort of product, through Kooth and so forth, than allowing the deterioration to happen. The old approach of mental health services in the NHS is wait for demand to hit us. We sit back, our job is to treat people. That's no good in my view. We've got to get in, working with others, partners, collaborate, both on technology, but also on community-based interventions that support people early, that prevent deterioration of health in the first place.
Thank you. And just to follow on from the speakers, I thought your observation was extremely acute, and actually the example you chose very well made, because I think it is a perfect example of how a system set up to treat illness just cannot repivot. In fact, we may be asking it the wrong question, asking it to repivot to be preventative. And Norman mentioned these new integrated care systems, of course, that are now in place. And to be honest, if they can't deliver on that agenda, then I'm not sure what they're for, because it is local authorities, it's social housing, it's a number of different things. And probably it is a different mentality and a different kind of service, which builds out from things like health visitors as opposed to surgeons, if you see what I mean. So I think there is a space in the kind of policy market almost for an intervention of that kind that we haven't yet seen. And just to close the panel off, and I think in doing so, obviously taking advantage of the opportunities of digital health is going to be huge. I think ICSs need to be given that much more explicitly to leverage digital health for preventative care. And if we were in any doubt about whether there's a burning platform, after all, we did extraordinary things when we had the burning platform of COVID. But the burning platform of mental illness is probably just as bad. Just in preparation for this discussion, I was looking at the Lancet review of the cost of mental illness globally. Over 400 million disability-adjusted life years lost to mental illness in 2019, 16% of the global total, and an economic burden globally of $5 trillion, which sounds almost unreal, but that is what we're talking about, let alone the human misery and pain that every one of those individuals feels. So hopefully that is enough of a burning platform to get things to change. And I think probably with digital health, for the first time, we have an opportunity to deliver radical improvements in productivity, efficiency of service, more prevention. And yeah, it's an opportunity we can't not take. So perhaps you could join me in thanking my excellent speakers, Norman and Sarah, for this morning. Thank you so much to you both. And thank you to Giant Health and to Shafi for the introduction. I hope you enjoy the rest of your day.